You're listening to This Week in Cardiology from theheart.org on Medscape.
Hi, everyone. This is John Mandrola from the heart.org Medscape Cardiology, and this is This Week in Cardiology for January 4th, 2019. Happy New Year, everyone. Today I'm going to talk about the external validity of the LA barbershop study, readmissions policies, abdominal fat, TAVR, and hypertension in pregnancy. First up is a discussion on the LA barbershop study. Sue Hughes of Medscape Neurology has an excellent story on the LA Black barbershop study that was recently reported 12-month results that upheld the 6-month results presented in the New England Journal of Medicine earlier this year. At 1 year, the pharmacist-led intervention within black barbershops maintained a 20 millimeter of mercury drop in blood pressure in the active arm. Now, in this column, Sue addresses the critiques of editorialist Dr. Keith Ferdinand, who is an endowed chair in preventive cardiology at Tulane, and he's also heavily involved in efforts to promote health in minorities. Ferdinand's editorial is co-written with Rachel Graham, lays out the external validity or applicability of the trial. They argue, yes, this was a great study and the intervention worked to reduce blood pressure, but it is expensive to run because of the doctoral level pharmacist. Also, B, used an ideal drug regimen in the active arm, much more so than what is done in practice. C, it enrolled a cohort of black men who, despite being economically challenged, mostly had insurance, social supports, and a high school education. And in other words, Ferdinand and Graham point out that this cohort is much better off than many of the minority groups in the South that they deal with. Their solution to the crisis in hypertension and other medical problems for minority populations resides in healthcare reforms that reduce the inequity of insurance coverage, that increase availability of primary care docs, and take down financial barriers to medications. And these sound like great goals, and they are great goals, but when I read their arguments, they're basically saying we should go to an NHS or Canadian system of care. And this is one where care doesn't depend on insurance. Primary care doctors run the show, and medicines are either free or affordable. Now, Sue Hughes reached out to the authors who responded to these comments with 4 big arguments. They said that this is an expensive model with the pharmacist. It would likely be cost effective, however, because of the large reductions in blood pressure. They noted they're currently testing the feasibility of this approach in other cities, such as Nashville. They also said they're working with insurance companies because obviously it is in the interest of insurance companies to control blood pressure. They're also trying to reduce the main driver of cost, which was the travel and time of the pharmacist, and they're using telemedicine to see if they can reduce the cost that way. So in general, the authors of the paper felt the success of this study was in using barbers to overcome the distrust in the normal healthcare system. And I led the podcast with this story because it highlights the tension in our unjust U.S. healthcare system. While I would love to see us move towards an NHS or Canadian system, as a realistic American, I think that is unlikely. Thus, I find myself closer to the author's take here. In other words, we have to work towards innovative solutions in which basic preventive care relies more on community and less on doctor-centered healthcare centers. I mean, really, treating blood pressure in most cases is not rocket science. It requires some basic education on lifestyle, the use of safe, generic medicines mostly, and some basic follow-up. I think we need to shake up our ideas on healthcare delivery, as a change to full-blown socialized medicine is unlikely to occur in the U.S. Next topic is on the 30-day readmissions rule, and this is because over the holidays, researchers from Beth Israel in Boston published another provocative observational study that associated worse outcomes with the implementation of the Hospital Readmissions Reduction Program, the HRRP. JAMA published a study with an excellent editorial. The HRRP was a stick, not a carrot, as it used financial penalties for hospitals that had higher readmissions for key diagnoses such as heart failure, MI, and pneumonia. This is a hot potato topic, and it was made even hotter when the authors summarized their findings in an op-ed in the New York Times. Now, first, just some brief background. I almost made the 30-day readmission issue one of the top stories of 2018 because not one but two observational studies published in 2018 observed that the HRRP associated with an increase in death at 30 days in 1 year. At a minimum, a neutral observer might worry that behaviors induced by this punitive policy might have led to harm. So in this most recent retrospective review, the one that was published over the holidays, this studied about 8 million Medicare fee-for-service admissions from 2005 to 2015, and this was an ecological analysis where the authors did a before and after an HRRP implementation kind of analysis. They used probability weighting mortality within 30 days of discharge following hospitalization for heart failure, MI, or pneumonia, and they stratified by whether there was an associated readmission. The key findings was that the HRRP was significantly associated with an increase in 30-day post-discharge mortality after hospitalization for heart failure and pneumonia, but not for acute MI. The overall increase in mortality among patients with heart failure and pneumonia was mainly related to outcomes among patients who were not readmitted but died within 30 days of discharge. Now, an accompanying editorial from Dr. Greg Fonarow pointed to this finding as a suggestion for causality. In percentage terms, the absolute increase in mortality were small, but considering their 8 million hospital admissions, these turn out to be lots of potential harm. Now, three of the authors put their findings in an op-ed in the New York Times, and in this piece, they wrote that while the problem is complex, the short-term answer was simple, and that is to err on the side of caution. The authors call on CMS to conduct an investigation into the patterns that they and other authors have found. And finally, they ask a question I've asked numerous times on this podcast. Why are policies that profoundly influence patient care not rigorously studied before widespread rollout? So I'm really conflicted on this topic. I worry that the penalties from this policy have distracted caregivers and hospitals from the important elements of patient care. But I want to be fair to my friend Dr. Harlan Krumholz from Yale, whose group developed CMS quality measures like these. Seriously, these are some of the smartest people I have met in cardiology, and if they see it differently, that gives me pause. Now, Krumholz has laid out his argument for the HRRP in a well-referenced Twitter thread that I'll link in the notes. He believes, A, there are hospital-level quality gaps that lead to readmissions, and the risk of readmission is a property of a hospital, not of the patient. They have a study published in New England Journal looking at patients who had 2 admissions to 2 different hospitals over a period of time, and the rate of readmissions was higher for hospitals that had low performance standards. His second argument for HRRP is that at least it changed the incentive structures for hospitals, as before these penalties were implemented, more readmissions meant more reimbursement. In other words, mediocrity paid. His third argument is that their studies from their group don't find increased rates of death after the HRRP, and neither does an analysis from an independent government group called MedPAC. Finally, Krumholz points to the fact that all of these studies are observational, and thus we cannot apply causality. And I say, finally, it's hard making sense of retrospective observational studies, and I think the main take-home here is that policies should face RCTs just as medicines and procedures do. Third topic today is about abdominal fat. Now, this podcast loves RCTs, especially elegant ones or RCTs that surprise us or those that study exercise and health. Danish researchers wanted to know whether the cytokine IL-6, which is lipolytic and released from muscles during exercise, also helps reduce abdominal obesity. This is an important topic because visceral or abdominal fat is harmful to health and associated with an increased risk of cardiometabolic disease, dementia, and all-cause death. Now, the less obvious reason to discuss this RCT is that IL-6 is directly downstream from the interleukin-1 beta pathway that was made famous by Dr. Paul Ridker's CANTOS study of canakinumab. Recall that canakinumab blockade of inflammation at the IL-1 beta pathway led to improved cardiovascular outcomes, but the nonspecific anti-inflammatory drug methotrexate did not. So back to the study. It's a 12-week single-center trial. The authors randomly assigned abdominal obese adults to 4 groups. 53 participants received IV infusions of either tocilizumab, a drug that blocks interleukin-6 signaling and is currently approved for the treatment of rheumatoid arthritis, or a placebo every 4 weeks. And they combined this with a no-exercise group or a bicycle routine consisting of several 45-minute sessions each week. They used MRI to assess abdominal fat mass at the beginning and end of the study. In the placebo groups, exercise reduced visceral fat by 8% compared with no exercise. That's not a surprise. In the exercise groups, the one with the IL-6 blocker and one without, the group that got the IL-6 blocker, the tocilizumab, they did not lose abdominal fat even though they gained fitness from the exercise. In fact, abdominal fat actually increased a bit in the group that got the IL-6 blocker. And worse, the tocilizumab group also increased total cholesterol and LDL cholesterol compared with placebo, both in participants in the exercise and no exercise groups. Thus, the authors conclude that IL-6 is required for exercise to reduce visceral adipose tissue mass, and that emphasizes a potentially important metabolic consequence of blocking IL-6. Now, obviously, this is a small study on patients without disease. IL-6 may act differently in healthy and diseased people, but what struck me about this study was the complexity of inflammation in the pathogenesis of disease. After hearing about CANTOS and canakinumab, it seemed that blockers of cytokines in that IL-1 beta pathway may all be fruitful. IL-6, for instance, is just downstream from IL-1 beta, and so therefore you would think that blocking that might be beneficial. But here we learn that IL-6 blockade raises LDL and blocks the lipolytic effect of exercise on abdominal fat. So I know inflammation is complicated. 4th topic, low flow aortic stenosis and TAVR. Now, one thing TAVR has brought with it is oodles of measurements by echo. Why? Because to get TAVR paid for, you have to meet criteria. So here is a common and tough scenario. An older patient has worsening heart failure, low ejection fraction, but significant aortic stenosis. Often, because of the poor LV squeeze, the gradient doesn't break the 4 meters per second threshold. The patient now has AS, but it is low flow, low gradient aortic stenosis. When I was at Indiana, Professor Feigenbaum always taught us you never give up on the ventricle when there is aortic stenosis. If the patient could tolerate aortic valve replacement, they would likely improve, as would the ejection fraction. Well, now we have TAVR, and the bar for intervention on aortic valve disease is obviously lower than it is with surgical valve replacement. So this is why I was drawn to a brief report in JAMA Cardiology looking at almost 300 patients that were in a TAVR registry. There were 2 groups of patients with low flow, low gradient AS. One had very severe LV dysfunction, EF less than 30%, and one with sort of moderate low EF of 30 to 40%. The authors were interested in changes in EF, periprocedural, and late mortality after TAVR in these patients. They also did dobutamine stress echocardiography in a subset with very low left ventricular ejection fraction, and the presence of contractile reserve was defined as an increase of 20% or more in stroke volume. Now, patients with low, very low LVEF displayed a greater increase in ejection fraction at the 1-year follow-up. The mean increase was about 12% versus 3.6% in the group that had only moderate impairment of LVEF. And in a subset of 92 patients who had very low EF, who had pre-procedural dobutamine stress echo, the results showed a lack of contractile reserve in 45 patients, or about half, but this had no effect on clinical outcomes or changes in ejection fraction over time. So in patients with low flow, low gradient AS and severe LV dysfunction, TAVR was associated with similar outcomes as in counterparts with only mild LV dysfunction. The TAVR procedure was associated with a significant increase in LVEF, irrespective of contractile reserve. Now, the authors conclude that this supports TAVR in low flow, low gradient AS, irrespective of the severity of LV dysfunction or dobutamine stress echo results. Now, I think that is a leap way too far based on a registry study, but these findings certainly warrants more study in this not uncommonly encountered group of patients. Last topic today is about hypertensive disorders of pregnancy such as preeclampsia, and I think this is rightly getting more attention these days. Using data from the prospective California teacher study, researchers sought to determine whether hypertension in pregnancy increased long-term stroke risk and whether or not aspirin or statin use reduced that risk. Now, the priors here are that yes, hypertension in pregnancy does increase the risk of future stroke and cardiac events. And in this study, about 5% of the 83,000 women did indeed have hypertensive disorders of pregnancy, and having it increase the risk of all stroke by 30% or a hazard ratio of 1.3. Hypertension of pregnancy did not increase the risk of stroke before age 60, however. The authors found a trend toward an interaction between aspirin use and stroke risk before age 60. For instance, non-users of aspirin had a higher risk adjusted hazard ratio of 1.5, while aspirin users did not. The hazard ratio there was 0.8. And this effect was not seen with statins. Now, the authors do a good job outlining the many limitations of this observational analysis, and the accompanying editorial is also good and explains that if there is a true aspirin effect, the absolute risk reductions are going to be small. These findings were published in the journal Neurology. Now, given the 3 negative aspirin trials that came out in 2018, an RCT of long-term aspirin use in patients who have hypertensive disorders of pregnancy is not going to happen. That said, it sounds reasonable to explore more population-level evidence to determine if hypertension during pregnancy should be considered an actionable risk factor for older age women. Intriguing to me is whether preeclampsia simply unmasks those at high risk or whether it causes long-term vascular effects that then confer later vulnerability. I don't know, but I look forward to learning more about this important topic. So that's it for the first This Week in Cardiology podcast of 2019. I'm grateful that you listened. Thank you. Until next week, this is John Mandrola from the heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the heart.org on Medscape.